This is our this is our 51st peculiar case series in renal transplant meet, and it has been 4 years. We never know that it has grown to such a big level that month on month we used to have this meeting. And as usual, we have two interesting presentations from two speakers from Chennai who are going to present an interesting cases regarding a post-transplant transplant infections. And as usual, we have three panelists this time, and we need to have a good discussion. So we thought of having a third panelist and welcoming Dr. Subbarao sir. Yeah, he is not new to this forum, and he has been here. He had been here for the last 3 or 4 sessions. He had a panel sessions, and he's a great person. Actually, he's a great person, and he's a senior most nephrologist and one of the pillars of nephrology in Apollo, and a lot of transplant, lot of exposures. And he seems to be very jovial, but when it comes to his job, he's very serious, and his academic insights is awesome. And his comments and inputs regarding the cases are always welcomed by all eminent nephrologists. Welcoming you, sir, for this meet.
Thank you. Thank you.
And joining him is Dr. Subramaniam Swaminathan, sir. That is, he's a new person to this forum, and I'm glad to welcome you, sir. He's Director, Infectious Disease and Infection Control, Clinicals Global, and Chennai and Bangalore, and he's a president of Clinical Society of Infectious Disease. And he's well-known person, and he has been associated with Dr. Rela in renal transplant. He's very much involved in renal transplant infections. So very less infectious disease persons are involved in get involved in the transplant, and we thought we have him in this forum because we need his lot of inputs, because these are two tricky cases, transplant infections, and we hope to get his a lot of inputs from him. And welcoming you, sir, to this forum. We are very much proud to have you here in this forum. And
Thank you.
And joining him is Dr. Vasant, and he's postgraduate of Sir Dr. Saravanan, who is the speaker in CMC Bangalore. And he's presently working as a senior professor, associate professor at PSC Medical College, Coimbatore. And he previously worked at Gleneagles, and he's the one who introduced Dr. Subramaniam sir for this forum, actually. He's a very knowledgeable person, and he's very soft and very supple. And his comments on the specular case series forum at that group at WhatsApp group, and it's always it's crisp and clear, and he's clear in concepts, and I think people will understand him while we have this discussion in this forum. And Dr. Vasant, thank you for coming and joining us in this meeting.
Thank you, sir.
And we have two speakers. First will be presented by Dr. Ajay Rathu, who is a consultant nephrologist at Curie Hospital. And he's a young budding nephrologist who used to do a good number of transplants. And his perseverance in making this case, actually, this is a very difficult case, and he's only lone survivor of mucormycosis graft. And it seems to be awesome that his perseverance and his management with the patients seems to be very nice and scientific. And hope he will bring good inputs from this case, and hope he will present well. Welcome, Dr. Ajay Rathu. And I'm happy to introduce Dr. Saravanan. He's a firebrand and nephrologist of Chennai, and he's doing a lot of transplant. And I used to attend many of his talks, and he's also a man of perfection, and he used to deal a case like as a professional nephrologist. And his cases, which is going to be present the next following session, gives a lot of, I'm sure that it will give a lot of information about a BK virus nephropathy. And he's an alumni of CMC Bangalore. And welcome, Dr. Saravanan, to this meet.
Thank you. Thank you, sir.
And I think his postgraduate, DRNB postgraduate, Dr. Gokul, is going to present this case, and he will be chipping in with his inputs and the insights. And without wasting much of the time, I will invite Dr. Ajay Rathu to start his presentation.
Thank you, sir. So my case for the day is post-transplant mucormycosis. So what the difficulty we faced in this patient, like from the point of diagnosis till the point of how to surveillance of the patient and to for the survival of the patient. So it was a journey for us, and I just want to share this journey. So every transplant is a story of science, hope, and uncertainty. Today, I just invite every one of our seniors and colleagues for a gripping journey of a patient who received a gift of life from a deceased donor kidney and then face a relentless adversary of angioinvasive mucormycosis. With immunosuppression protocols evolving and organ acceptance criteria expanding, donor-derived infections, including invasive fungal threats, have moved from theoretical risk to clinical reality. Let's walk through the clinical crossroad where the rapid diagnosis and multidisciplinary action have taken place here. Coming to basic epidemiology and clinic context of mucormycosis, the incidence of post-transplant mucormycosis is around 0.4 to 0.5 per thousand kidney transplants, which is around 0.04 to 0.045%. And in which the vaso-invasive mucormycosis mortality ranges from 76% at 90 days to 93% at 1 year. Overall post-transplant mucormycosis is around 48%, in which the donor-derived mucormycosis is extremely rare and almost always fatal, in which the management plays a bigger role here. Only when we use only antifungals here, the survival rate is around only just 32%. When surgical is combined with antifungal, it raises up to 70%. Few words about donor-derived mucormycosis. So, what makes donor-derived mucor so dangerous? It's always present very early. So before diagnosing itself, it makes its presence and it kills the patient. So that is very dangerous, and often already it is systemic and vascular at a transplant, and it is very, very aggressive. The survival from donor-derived mucormycosis is extremely rare, as discussed before, and only isolated case reports are been there, and very, very few survivors are there. And what happens is it usually has a multi-organ recipient is there, and a rapid progression and high mortality. Coming to our case scenario here, the recipient background. So his native kidney disease is FSGS. He has already underwent a renal transplant in 2002, which was a live transplant, and he had a graft dysfunction in 2014, and he's on maintenance dialysis from 2016 and registered under DDRT. And he had an uneventful hemodialysis session till 2024 when he had undergone the DDRT. He was a highly sensitized recipient, so his PRA was around 44% in class 1 and class 2. So SAB was done. High MFI antibodies, more than 10,000 was seen in both class 1 and class 2. Maximum, there were few antibodies which was around 18 to 19,000. So we planned for a desensitization regime. Pre-transplant, he was the first rank. So we had we planned the desensitization and transplant in a well manner. So we planned for, we gave him around 100 grams of IVIG. Rituximab was also given, around 200 mg was given. And all these were given just a week before transplant, and then we accepted the kidney. The clinical goal was to lower the antibody burden, and with this, profound immunosuppression increases the risk of infection. Coming to the donor background, he's a 35-year-old male, BMI of 25 with no comorbidities, and he had a slip and fall from a height. ICU admission was there and was on ventilator for 8 days. His renal function was normal. His kidney, liver, and heart were harvested by multi-hospitals in Chennai. Coming to the technical details and immediate post-operative course. So his cold ischemia was around 3 hours. Anastomosis was to the external iliac artery. And coming to day 1 to day 3 was he had a good graft function. His urine output was good. His creatinine was falling. His lowest creatinine was around 1.4, and he had a good flow in the Doppler. The first sign started the day 4, where there was mild decrease in urine output. There was mild increase in creatinine. So we planned for renal biopsy on the day 5. So then we did the biopsy on the day 5, and the report came on this next day. So there were two things in the histopathology. One was ATN. So which was expected in a post ischemic perfusion injury in a DDRT patient. But there was something called patchy cortical necrosis. So patchy cortical necrosis is not a diffuse or global injury. It is a segmental focal pattern suggestive of focal vascular compromise. So again, when we're thinking what was the cause of this patchy cortical necrosis, so the thing which got into our mind was acute rejection, but it was unlikely because C40 was negative. No other features of rejection was seen in the biopsy. It could have been TMA, but no thrombocytopenia, no drop in HB, no cystocytes was seen. Vascular cause could have been a differential diagnosis, but Doppler was reassuring. Even after the biopsy, we did a Doppler. Doppler was normal. There was good flow in the and the angio infection. We were not thinking about that at that point because the biopsy report came around like 6 p.m. in the night, and around 10 p.m. in the night we had the event, which is the first emergency we had. We had around a liter of blood in the blood drain, which was few hours after the biopsy report. And what we did was we took him for emergency exploratory laparotomy, and the spontaneous bleed from posterior abdominal wall was seen. So I still remember my urologist calling me in the night around 11 o'clock saying like, Ajay, you did the biopsy and it is bleeding. The whole the tube is full of blood. Around 1 liter of blood was lost. So it was presumed like it could have been biopsy site or surgical or vascular. But what we saw here was spontaneous bleeding from posterior abdominal wall. It was not from a major vessel. It was just sprouting blood vessels were seen. Hemostasis was attained and we came out. Patient was stable post-transplant, but we were all puzzled what was the cause of bleeding. We were totally puzzled that time. Why would the posterior abdominal wall suddenly bleed on day 6 in an otherwise stable post-transplant patient? We were completely, what happened next day was the horrible thing which happened. After this surgery, he went in for his urine output completely stopped. We did a Doppler the next day morning. It showed no graft flow, and we did an angiogram. Angiogram showed absent flow in the renal arteries and renal vein, which showed extensive thrombosis involving the external iliac artery. So after discussing with multiple people, we ended with emergency graft nephrectomy. So intraoperatively, what we found extensive thrombus of the external iliac artery, anastomosis site, and thrombectomy was attempted, and a saphenous venous pouch reconstruction was done. And cause was still at that point were unclear. I was thinking like because of the spontaneous bleed, they were searching for the site of bleed that night. Because of multiple handling of the graft, the thrombus occurred. That was the first thing which came into my mind. But what caused the complete graft thrombus surgery? Because of the surgery which he had the day before, or some rejection we missed, or some unknown infection. So this was the thought process in our mind that day. And within 24 to 48 hours, we got the histopathology, which revealed the diagnosis. Extensive cortical necrosis was seen, and angioinvasive mucormycosis was confirmed. We found broad aseptate right angle branching hyphae fungal invasion into the vessel wall, which was into the thrombus. So now everything came, which made sense for us. So day 5, the patchy cortical necrosis could have been the early angioinvasive infection. Day 6, the bleeding could have been the vascular invasion or the erosion of the vessels because of the BFAR. And the day 7, the thrombosis, the massive fungal burden in the vessels, which led on to the thrombosis. So the next step for us was immediately start the patient on antifungal therapy. So the biopsy on day 5 was the first clue. The HPE confirmed the diagnosis, but it was completely missed with the shift form of the disease. Within 48 hours of the biopsy, we went for the nephrectomy. So within 48 hours, everything happened to us. It was just like a cyclone hitting us. So before thinking about the biopsy, the bleed occurred. When we thought thinking of the biopsy, the nephrectomy occurred, and the next thing was mucormycosis. And coming to antifungal, we started the patient on a conventional amphotericin B, 1 mg per kg. The rationale behind this, it is rapid initiation, proven efficacy in mucor. And the only point is it is nephrotoxic. So right now the patient is on dialysis, so there was no point about it. So we started him on conventional thing, and we preferred conventional over liposomal because of the cost factor. And patient tolerated the drug very well for 1 week. Post this thing, he was given amphotericin B. Then came the third emergency, the most important thing, which is external iliac artery bloat. So after 7 days of nephrectomy, the patient was almost stable and on dialysis. And patient suddenly had an active bleeding to the drain. And we did a CT abdomen contrast, which showed massive vascular erosion from the fungal invasion because of fungal invasion. Patient had to undergo emergency surgery where patient had external iliac artery excision. Completely it was excised and completely it was debrayed. The complete external iliac artery was debrayed. And we were very much worried about the ischemic limb syndrome. And we even talked to the patient and attenders to remove for the amputation of the limb. But as they were not willing for the amputation, what we did was we started the patient on anticoagulations and other limb preservative things. And the HP again, the excised vessel again confirmed the angioinvasive mucormycosis with the extensive invasion. Then what happened was this is when we thought this is not a routine post-transplant complication, mucormycosis. It is a predator attacking the vascular system. Then we escalated the antifungals to a dual antifungal. So we started him on posaconazole. So the ration behind it is monotherapy is inadequate in angioinvasive mucor. So the survival is only 32%. When we combine amphotericin B and azoles, they achieved around 70% of survival. So posaconazole penetrates tissue well, especially in bone and skin. So amphotericin B was continued. IV posaconazole 300 mg daily was started. Later we converted into oral, but the difficulty we found was when we converted him to oral, he did not reach the levels. So we changed him to posaconazole twice daily 300 mg. And in this course of time, we have done multiple fungal cultures repeatedly. All the cultures were negative except for the only clue or only evidence we had was the pathology. So the lesson here is do not rely on the culture negativity for invasive fungal infection. So this was the drug which was. Coming to other challenges which we faced in this patient. So it was a multi-organ complication. It was a complete rocky course for us. First, he had a hematoma at the surgical site because of the anticoagulants, which was managed conservatively. We had to cut down his heparin dose half. So we reduced the dose and it was managed conservatively. And he had surgical site infection, which grew MDR Klebsiella. The only treatment was which we gave was IV colistin for him. And with IV colistin, the response was really good. And he had intra-abdominal collection in left iliac region, which was drained percutaneously, and that too also had some mucor invasion particles. So we instilled amphotericin B in dressing too. The next thing which we saw was he had a massive left pleural effusion. So he had complete collapse. So we had to put an ICD for him and BAL was done. In BAL, surprisingly, we found Aspergillus growth. This was a different fungal organism from mucor. So this indicates opportunistic superinfection in a severely immunocompromised patient. So at this point, the significance is posaconazole does not cover Aspergillus. So we had to switch him on to a broader antifungal. So we switched him to isavuconazole. So isavuconazole is a broad spectrum triazole. It covers both mucormycosis and aspergillosis. It has better tissue penetration than posaconazole. Loading and maintenance tools are optimized. So from October 2024, so his transplant was on July. So from October, he was on isavuconazole, which the dose is around 200 mg IV loading, Q8 intervally for 48 hours, followed by oral isavuconazole can be given once daily. So he tolerated the drug very well, and he did not have any LFT derangement. So this is how posaconazole doesn't have much action towards aspergillosis. So isavuconazole was preferred, and tissue penetration is good or better than posaconazole. Oral bioavailability also is good. Coming to surveillance, so we used PET-CT as a strategic time point and as for surveillance. So as soon as we started, we knew he had mucormycosis. We did a PET in August to confirm the localized infection and no new issues there. And in October, we did another PET. And after seeing that, in October only, we stopped his amphotericin B. In March, we continued the treatment for 6 months. So isavuconazole, we stopped it around around February. And after stopping it, we did in March, the PET scan was done, which was reassuring, and there was no new lesions. And this July, we did another 1 year post nephrectomy follow-up, and there was no new lesion. So why PET? It detects the active infection. So hypermetabolic activity can be found, and it is useful for monitoring response and guiding treatment duration. And it helps to decide when to stop the treatment. That is more important for us here. So serial image guided our therapeutic decisions and confirm successful eradication of infection. So these were the different dates and different contexts and multiple things which we did. So the transplant was done midpoint of July, and he had his nephrectomy in 29th of July. So the blowout was in the first week of August, and that is when we started the amphotericin B and posaconazole. In end of August, he had the MDR Klebsiella, for which we used colistin, and first week of September he was doing good, and we stopped him on amphotericin B. And in the end of September, he had aspergillus infection, a breakthrough infection, for which he was switched on to isavuconazole. And the October, after starting isavuconazole, he had a good improvement in PET, and we stopped the treatment in mid of February, which was 6 months from the start. And a follow-up CT was done in March as well as in the July, which found no new lesion, and the patient is doing well now. So coming to long-term clinical recovery, physiotherapy was done, and mobilization was started as early as possible. And in early in the first 6 months to 8 months, he was walking with help of a walker. Now, right now, after 1 year, around this time, he's trying to walk without any support. And vascular recovery wise, he did not have any limb ischemia after the external iliac artery excision. Doppler was done regularly. The lesson here is, even though we thought like he would need a amputation, the body is remarkable in adapting the changes, and he's doing good in dialysis. He's doing 3 times dialysis now, and he has a good quality of life in dialysis right now. And after 1 year follow-up, the PET CT has no new lesion. The clinical status is stable, and patient is alive and well despite the graft loss. So even though we lost the graft, but the patient has been saved, and this is our ultimate. So the learning points here is, so the diagnosis. So here in diagnostic wise, histopathology is always gold standard in invasive fungal infection. So patchy cortical necrosis on early post-transplant biopsy is a red flag for vascular pathology. So whenever a patchy cortical necrosis come, always a back of our mind, we should think about some vascular pathology, and early mucor can be detected. And don't rely solely on the fungal culture. In the whole picture here, in the last 1 year, not a single fungal culture group formed. And early biopsy when graft dysfunction is there also yields critical clue. Therapeutic strategies, monotherapy for angioinvasive mucor is not recommended. Always combination therapy is better. Dual antifungals is always better compared to monotherapy. And considering the broad spectrum coverage, when breakthrough infection is there, then an add-on aspergillus is there, always consider isavuconazole. And dose is always like therapeutically, we have to monitor the drug levels and efficacy can be done. Surgically, we should always have a low threshold in re-exploring the patient, and low threshold for exploration when unexplained bleed or thrombosis occurs. Angioinvasive fungal infection often requires a lot of surgeries and emergency surgeries. Graft nephrectomy may be life-saving despite the graft loss. Surgical source control and antifungals are the best outcome. Multiple surgical intervention is necessary in all patients. Coming to immunosuppression management, aggressive reduction in immunosuppression in invasive infection is critical. Balance immunosuppression to control the infection and allowing the graft function if salvageable. So always patient survival is more than graft survival. Always have a donor-derived infection vigilance. It is always rare. Even though it is rare, it is always catastrophic. In this case, for us, the other kidney, the person, the hospital who has taken the other kidney, the patient had an unknown sepsis around 6th or 7th day, and he died because of that. And the other organs which were retrieved by the other hospital also, the patient died within 10th or 11th day. Even before we got the histopathology reports, the all other patients who have received the organ have expired. So early aggressive presentation should raise suspicion, and screening protocols for donor risk factors like ICU stay, environmental exposure need should be strengthened, and multidisciplinary integration has to be done. A rapid case conference between nephrology, infection disease, urology, and radiology is very much needed. And in this case, it was very, very helpful for us. The infection disease specialists and the urology was very helpful for us, so that the patient has survived. And surgical expertise and medical expertise always have a better surveillance. PET-CT is useful in monitoring response and guiding the therapy. That should be done. And long-term follow-up, like at least for a month, at least for a year, it has to be done. And for at least for 1 year, PET scan has to be done, and eradication should be confirmed. So against all odds, the takeaway message is the numbers said the patient should not have survived. The vaso-invasive Mucar has around 93% mortality, 76 to 93% mortality. The donor-derived mucormycosis is always universally fatal, and early artery blowout is a surgical emergency with very, very high mortality. So even with these bad numbers, our patients survived. Why? It is because of early suspicion despite rarity, rapid diagnosis with the help of histopathology, aggressive multimodal therapy with surgery as well as dual antifungals. And it was a teamwork and coordination, willingness to sacrifice the graft for the patient, and long-term surveillance and commitment from the patient and the patient attenders. So in transplantation, we navigate the razor edge between the enabling life and preventing catastrophe. This case demonstrates that when catastrophe strikes, vigilance, expertise, and teamwork can defy the odds. Stringent surveillance, low threshold for suspicion of infection, and rapid multidisciplinary response are life-saving measures in highly immunosuppressed individuals. We don't always save the graft, but when we save the patient, that is our ultimate victory. Thank you.
Thank you, Dr. Ajay. It's a wonderful presentation. Your slides are very good, actually, and you are narrated in a good way. And please unshare your screen. So, panelists, we have 10 minutes of discussion left. And Dr. Subbarao sir, your comments on this case, please.
Yeah, I think we should audit the where the organs have come from. I think which hospital is that? I think something has gone grossly wrong there.
Yeah.
All the recipients have died. I think
But they haven't diagnosed what is the cause, but most of them.
I think most of them must have died. Died of mucor only. What else? You have so early death. I think this is I think there has been some contamination in the fluids, most likely perfusion fluids. With this fungus, it looks like.
Because you encountered that Foley's catheterization, no, sir. Foley's
no, mucor. This is this has gone into the blood. It is not from the most commonly mucor comes from the stitches also, the stitching materials also, but it doesn't look like this. This looks like more of something has gone into the organs. So most likely, my impression is this looks like contamination of one of the perfusion fluids.
Thank you, sir. Dr. Vasant?
Good evening, all. It's a really tough case, Dr. Ajay. You have managed very well, and you have done a justice to the patient. Sometimes we'll be reluctant to tell go for nephrectomy, but it's our duty to convince the patient to go for nephrectomy. In that way, we have managed very well this case. And second kidney and the rest of the organ also have the same problem you said. So most likely it's a donor derived. And as Subbarao sir said, I have seen a case of Aspergillus infection immediately after post transplant due to preservation fluid contamination. So that's another possibility. It may not be a just from donor tissue alone. It may be due to contamination of the preservation fluid. That also we have to keep it in our mind. I thought of asking about PET, and you said that you have done it after some time. And it's an angioinvasive mucormycosis, so that definitely it might have crossed various places. So that early PET will tell some, it will give some idea where all it has gone. And anyhow, the patient is already on antifungal, but sometimes that may need a surgical debridement if you do it very early, or it may be useful in early follow-up. Otherwise, I would have done the same thing, but it's a very tough case.
It's a very tough case to handle. Thank you, Dr. Vasant. Now the man of the moment, Dr. Subramaniam sir, your comments, please. You would have seen a lot of such kind of patients, and your insights, please.
So one
actually,
point, sir is also involved in this patient, sir.
Yeah, so
person-
he had discussed this with me as well. So I think Dr. Subbarao hit the nail on the head in that when you have fungal infections this early, donor-derived possibility has to be considered, and we have to look at contamination. I wish this were rare. Unfortunately, if you look at case series which have come from the Middle East, in the days gone by when people used to come here for organs, there are multiple series of patients requiring graft nephrectomy to save their lives after having had their transplant in the subcontinent, not just India, but Pakistan as well. And this has also happened in places like Turkey. So therefore, the possibility of contamination of fluids, preservative fluids and things like that need to be taken seriously. It cannot be excluded. And I think that's the, that's the big elephant in the room. Now, as far as the management is concerned, lovely. I think early identification, nephrectomy, the source reduction, obviously very, very key. Yes, cultures are a little difficult to get, but because remember, Aspergillus is made of beautiful small groups of sperm. It's a septate hyphae. So even if you cut it, there is enough hyphae, enough cellular material left behind for it to grow. These are large rods. So if you cut it, the whole thing will die. Therefore, the problem is when they process it, very often you are not able to get a culture. So very often what we do is we ask for the culture knowing fully well that zygomycosis will not grow well. But we often ask for molecular methods like ITS and things like that. Why is this important? Because some zygomycosis actually don't respond to Ampho-B. For example, Cunningham-Ella, which is fairly rare here, is resistant to Ampho-B but susceptible to azoles. Now, somebody else has asked, why worry about Aspergillus if it is if you're giving Ampho-B? Please understand that the commonest Aspergillus species in India is not Fumigatus, it's Aspergillus flavus. And Indian data suggests that about 30% of our Aspergillus flavus is Ampho-B resistant. Therefore, if you're using Ampho-B for treating Aspergillus, you have to be very careful. You're likely to burn your fingers. And it's happened before, it is likely to happen again. So I would rather trust an azole for Aspergillus than Ampho-B. But if you have zygomycosis, obviously the agent of choice is Ampho-B, and then overlap with an azole and get on the azole. Now, the other point that you mentioned was posaconazole, you had to give a higher dose. One important thing everybody should realize, I don't know how many of you know this, the 300 milligram of tablet of posaconazole does not work. It does not work. You have to use the 100 milligram tablet, 3 tablets of it every day. Again, there is variability between manufacturers. The 300 milligram tablet, all brands are made by the same person. Therefore, the same problem affects all people who market the 300 milligram tablet. And in the ID community, we do not use the 300 milligram tablet. We are only using the 100 milligram tablet as 3 tablets together. And clearly, that makes a big difference to the blood levels. I'm not sure why you said it doesn't work for Aspergillus. Actually, posaconazole is licensed for use against invasive aspergillosis. And as far as the lung is concerned, please understand, mold infections rarely produce effusions. If you say effusions, you don't think of mold infections. Yeast, like Cryptococcus, can do that. But molds don't cause this one. See, they are tissue invasion. They literally go through like a cancer. They will go through and through. They will not cause effusions. So if you see effusions, don't think of fungal infections. And keep in mind that being an agrarian country with a lot of construction, finding Aspergillus in the tracheobronchial tree is not at all unusual. In fact, when we look at our lung transplant patients, when we have lungs coming in, invariably they come in with Aspergillus because, if it comes from the community, especially from a rural background, you are going to find Aspergillus sitting in the tracheobronchial tree. That doesn't mean it's invasive, but you should look and see if there is invasion, especially in a vulnerable adult like a transplant patient. So a search is necessary, but finding it does not necessarily mean there is invasive disease. The distinction has to be made. And anyway, in this case, because an antifungal was mandatory, absolutely fine. You're going to be covered as well. Lastly, the duration of therapy. When I did my fellowship at Wayne State in the US, my boss used to tell me when they start transplant patients on antifungals, it was practically lifelong. I always disagreed with that because I thought it was excessive. But now the pendulum is moving towards shorter and shorter course of therapy. Again, it is dependent on how much source control you have and whether you have the right agent on board and things like that. The majority of my patients actually today are getting only about 6 weeks of therapy. Some of them go on to 3 months, but 6 weeks of therapy is practically the most common. Again, for this kind of disastrous disease, I'd probably give 3 months because you're talking about intravascular infection. So I would definitely not do less than 3 months. Is there value in doing more? It's not clear. Finally, I think PET scan is a beautiful test to identify the extent of the disease and also as a guide to stopping therapy. I've been doing PET scans for end of treatment as an end of treatment confirmation for a few years now, and a lot of my colleagues are also doing that. And I think it's a useful modality that way. So yeah, it's underutilized for this, and certainly something that's useful. So keep in mind that cultures are not necessarily your go-to. Things like gene sequencing is actually quite cheap. Shankara Nethralaya does it, and it's quite good.
Okay. Thank you. Thank you for. So here a good point is you covered a lot of things. And what is the difference between using the different kind of amphotericin B preparations like?
Okay, so the good old gold standard has always been plain amphotericin, desoxycholate. Let me make this very clear. If cost is not an issue, I would go for liposomal simply because it's easier to use, toxicity is less, and you're able to give it unhindered on a day-to-day basis. With plain ampho B, the need to stop therapy is always a big problem because of toxicity. But having said that, plain ampho B is still a very, very, very good drug. So let's not blacklist it and say it's a terrible drug. It's still a very good drug. There is nothing wrong in using plain ampho B if you're pushed to a corner. Absolutely fine. But if cost is not an issue, there is lipid formulation in ampho B. Again, here there's an important point. Not all formulations of ampho B are created equal. There is truly liposomal and there is lipid associated. Now, again, how they convert towards each other is very difficult to say. Unfortunately, we only have in vitro data. We don't have in vivo data to show one better than the other. If you look at the US, if you look at Ebelset and Ambisome, which is one is a lipid formulation and the other is truly liposomal, they do say that there is a clear difference between the two. But having said that, our Indian preparations, there are quite a few, and it's difficult to say one is better than the other. So what can we go by? During the COVID time, when there was a massive shortage of amphotericin preparations, some of the lipid preparations were used quite extensively in some of the major centers. And CMC actually had a lot of experience with this. And they noted that the lipid formulations actually did very, very well, just as well as they would have expected the liposomal formulations to work in the setting that, everything else was done. Control your sugars, do good debridement, watch what's happening. If you do all of that, then the lipid formulations of ampho B also did as well as the truly liposomal without too much side effect, without too much cost either. So I think it is definitely something we should consider in our setting if the truly liposomal form of amphotericin is too expensive for daily use.
Thank you, sir. One last question from you. That what is you say there is a PET scan for endpoint for the therapy, sir. So does it hold good for all any mucormycosis in the body, right? So at what intervals you will do that PET scan?
Okay. So I'll give you an example. I had a heart transplant patient who 5 days after surgery started developing loose tooth. A week after surgery, teeth started falling out. And the dentist who had seen him along with the cardiothoracic team and one of my colleagues was walking by, and then she was like, no, this doesn't sound right. And she popped in to see the patient. We don't see every patient every day. We just popped in to see the patient, and we realized there was something wrong. Long story short, there was alveolar mucormycosis. So the dentist went in, he pulled out all the teeth, and the maxillofacial surgeon, ENT surgeon, everybody worked together. All good. We gave 6 weeks of therapy. The guy was completely fine. There was absolutely no clinical evidence of disease. Even the X-ray looked fine. We did a PET scan because we like it. And what happened was we found that there was still active disease in one root alone. So we told the dentist to go back in and pull out that tooth. And lo and behold, there was a focus of mucormycosis in that root alone. Now, if I had stopped there, we would have had a relapse and this guy would have died. Now, because we did that, we were able to pull it out, give him another 6 weeks, and then 6 weeks later, followed up with the PET, showed that there was no activity, and then we stopped and he didn't have a relapse. So the point is, remember that, see, we have tests to say there is a problem. There is no test to say no problem. The test of cure is time. So we cheat by doing a PET scan to kind of predict the future. Is it perfect? The answer is no. But is it quite good? The answer is yes. So I do use PET as a test of cure because radiology is very ineffective in this setting. There's going to be a lot of tissue damage, scarring, and trauma secondary to both the disease and the surgery. So how do you know what is old and what is new? That's always difficult. And that's where PET cuts to the chase and tells us, is there metabolic activity? If there is no metabolic activity, that's a reasonably good sign that there is probably no active focus of infection still left behind.
Thank you, sir. Thank you. One last question, because already we are running out of time and you have to join. Right. Is there any dose monitoring for posaconazole?
There are a lot of questions, Raj.
Yeah, a lot of questions.
Yeah, absolutely. All azoles ideally should be dose monitored because it's very difficult to predict. Understand that voriconazole is very difficult to analyze simply because it's second order kinetics. So I don't know. Most of us probably got into medicine because we hate mathematics. I'm probably an outlier here. I love mathematics. So I do the calculation in my scribbling pad and try and figure out what the dose is for second order kinetics and adjust it according to that. So voriconazole is far more difficult to adjust that way. POSA is first order kinetics. Therefore, if you're on the same brand, because brand to brand changes can happen, if you're on the same brand, you can predictably say how much your level will be if you adjust the dose. So that is the good news. Second, posaconazole, your therapeutic window is very large. The difference between a good dose and toxic dose is very far away, unlike Vori. And same thing for Isavo for that matter. So for most antifungals, see, even for ITRA, if you look at it in the Western world, they do levels. I've had patients who have failed. I have a kidney transplant recipient who's just had a retransplant in Bangalore. I also handle work in Bangalore as well. So this gentleman, post-transplant, developed disseminated histoplasmosis, got Ampho-B, got itraconazole, and relapsed after that. And then he was sent to me. I realized that he was probably a hypermetabolizer of the azoles. And so I put him on POSA because POSA levels I can do. Vori levels, ITRA levels I can't do. And when I did the POSA levels were quite low. So I gave him 400 milligrams of POSA a day, gave him about 6 months of therapy, made sure it was clean, made sure PET was negative. And he has since had the repeat transplant. Gave him 6 weeks of POSA immediately post-transplant for preventing flare-ups again. And now he's been off prophylaxis for about 8 weeks now, and he's doing very well.
Right,
so the point, sorry,
sir.
Yeah. So the point is that I think drug levels are critical, especially in these kind of settings, simply because if you don't know your blood levels, you're going to be in trouble. In transplant, you have a big advantage. Always look at your TAC. If you have used a good level of an azole, your TAC should fly. If your TAC is not flying, that is reason to be scared. That's reason to be worried. Your azole is probably not good enough. You're not getting enough levels.
We'll get another question. That serum beta D-glycan for guiding therapy. What is the value of serum beta?
So there are two biomarkers. Well, actually, there are three biomarkers. I'm not going to go into histoplasma antigen. Let's talk about beta D-glucan and Aspergillus galactomannan. Both of these are only meant for screening and for diagnosis. They are not markers for follow-up. And please keep in mind that beta D-glucan and galactomannan neither will be positive in mucormycosis. Beta D-glucan will be positive in pneumocystis pneumonia. It will be positive in Candida. It will be positive in Aspergillus, not in mucorales. Galactomannan will be positive in Aspergillus, Histoplasma, and a few other endemic fungi, Fusarium, for example. But it will not be positive in mucormycosis. Any
Among
of
the
these
blood
guys,
and body fluids,
Hmm.
which is more reliable, sir?
okay, again, each one has a cutoff, and all these cutoffs are based on stem cell transplant recipients. In lung transplant, we have worked out our own numbers in terms of how it should be used for galactomannan, bile galactomannan. But for all the other things, there is no cutoff. Please keep in mind also that there is a lot of contamination that happens. If your patient has received piperacillin tazobactam will give the patient free galactomannan. So your galactomannan will be high. So please be careful about that. Second, a lot of the tubes that you have, which you collect your samples, blood and whatnot, they also come preloaded with galactomannan. So you have to ask for galactomannan free tubes and make sure that the blood or whatever sample you're sending is sent in that. Otherwise, your report is garbage and your report will be high and you're wondering what is happening. So please be very careful about all these things.
Thank you, sir.
Sure.
Well, sir, you have asked one question. We'll take the question after the second presentation. Dr. Saravanan, so thank you for the presentation and discussions.
Yes, sir.
Dr. Saravanan, please share your slides and
Yeah.
start your presentation. We'll have discussions after this presentation, please.
Because we try to finish it very fast, like no, because the aspergillus anyway is like very rare to see in a post-transplant setting, whereas BKV, like no, nowadays very commonly, like no, we have an some idea about of managing BKV. So we'll finish this discussion very fast, and like no, we'll make it like a point of discussion, or we'll make a consensus, like no opinion about others, like how to go about this case, like whether something differently can be done in our patient for the better benefit for this that particular patient. So we'll finish it very fast, and like no, we'll make a good discussion at the end, like no, so that we can get various inputs for the benefit of that patient. Gokul, we can start.
Yes, sir. Good evening, everyone. Today I'm here to discuss a case of about unwanted guests since early post-transplant period. So this
There
is
is some
about
background activity.
That's
Can you
activity,
please-
sir.
Tangapati, just look at it.
Tangamani, there is some. Oh, yeah.
Yeah. Okay. I think
I
it's
think Tangamani is a culprit.
yeah.
Yeah.
This is about a 44-year male, a known hypertensive, hypothyroid, chronic kidney disease since 2021, presumed IgA nephropathy. He underwent renal transplantation on August 9 in 2024. Sorry, it's a mistake. Donor is a father, HLA is 7 to 12 match, and CDC flow cytometry is negative, and total ischemia time is 1 hour 30 minutes. He had an intra-op oozing, which leads to a hypotension, which required NORAD support, and he also had a decreased urine output in the immediate post-op period. So on POD 0 on the day of surgery, his PP is 160 with a NORAD of 5 ml per hour. So in view of hypotension, blood and urine cultures were sent, and he was started on antibiotics. Transplant kidney Doppler showed a normal flow, but with a perinephric collection of around 1.8 centimeter. And he was given ATG 50 milligrams and Solumetal 1 gram. And he was started on tacrolimus 3 milligram BD and MMF 360 mg BD. On POD 1, he had a decreased urine output. So in view of decreased urine output, tacrolimus was stopped, and he was BP was maintaining with the NORAD of 2 ml per hour. It was slowly tapered and stopped, and creatinine has come down to 5.5. In view of anemia, he was given one PRBC also. CT KUB done showed perinephric hematoma of volume around 270 ml around a transplant kidney. So on further post-op days, his tacrolimus was slowly reintroduced as his creatinine was coming down. So this is at imaging showed a perinephric hematoma around the transplant kidney. So in view of short time, I'm running fast. So on further on POD 6, he had a drain of 570 ml, but creatinine was coming down to 1.4. So he was discharged with the drain tube and with the Viceron of 30 mg, MMF of 360, 102 tablets, and tacrolimus of 3 mg BD. So on further follow, day after the discharge, his creatinine was 1.1. So tablet Septron and Valgan was added. So on further follow-up, his creatinine was slowly increasing to 1.6 with TAC level of 6.3. So transplant kidney Doppler done, which showed 11 cross 6.5 centimeter. with 150 cc of fluid collection, was minimally extending to perinephric region, and there was no HUN. So his creatinine was slowly rising. We did a renal biopsy, which showed a tubular epithelial injury, which patchy areas of interstitial inflammation, focal tubular atrophy. So it suggests a possibility of early acute cellular rejection. So we have given 3 doses of injection Solumetal 250 mg. So and further, uh, the post Solumetal injection, his creatinine was 1.6, but he continued to have a drain output of more than 200 ml per day. His creatinine was still 1.8. So his urine, we suspected any infections. His drain culture was same, which grew E. coli and Pseudomonas aeruginosa, and appropriate IV antibiotics were started. And urine BKV virus was sent, which showed 10 to the power of 8 copies, which was more than reference range. So we have immunosuppressions were modified. So we reduced Visolone from 30 mg to 20 mg OD, and MMF from 360 1022 BD, and tacrolimus from 3 mg BD to 2.5 and 3 mg. And in view of BKV, we have started leflunomide 20 mg OD. On further follow-up, his creatinine remained at 1.6. Also, he had a fever for 4 days. So transplant ultrasound kidney was done, which showed 360 ml fluid collection, displacing the bladder with mild PCS and ureter dilatation. So he underwent an exploration and drainage of the pelvic abscess, and that culture showed ESBL E. coli. He was treated with the appropriate antibiotic of ertapenem for 14 days, and immunosuppression was still reduced to Visolone of 17.5 and tacrolimus 2.5 BD and MMO of 360 BD. So on further follow-up, his drain amount reduced, and at a stage his drain was removed, and repeat ultrasound showed normal transplant kidney with mild prominent PCS. So in September, his creatinine was around 1.2 and slowly increasing to 1.4. IV antibiotics course was completed on roughly 1.5 months post-transplant. His urine BKV was high. So we have further transplant kidney Doppler also showed no collection. So we have further reduced the immunosuppressants. And we have also given IVIG of 1 gram per kg to in total 60 grams. So in October also, his creatinine remained at 1.4 to 1.5. So in November, that is around the fourth month after the transplant, his urine BKV was increasing in trend, and plasma BKV also showed positivity, and decoy cells were positive. So we'll still reduced our tacrolimus to 2 mg BD and moved to 180 BD. On further follow-up, his creatinine was remaining high only. So he has stopped the MMF, and azoran was added. And further course, in Jan 2025, his urine BKV was still high. So we have given IVIG of 30 grams, that is 0.5 grams per kg. And his total WBC counts were coming down. So azoran was stopped. So you are giving a monthly IVIG of 0.5 grams per kg. So in March and April also, his creatinine remains still high, and urine BKV is also more than 10 to the power of 8 copies. So we have given IVIG 30 grams in April also. And he was continued on tacrolimus 1 mg BD and leflunomide 20 mg and low dose steroids. In May, he had extensive tinea corporis, which was managed with itraconazole. In June 2025, his creatinine is 1.94 and urine BKV is still high, for which he was given 20 grams of IVIG. In July, his creatinine is 1.8, for which we have changed to Advograph 1 mg. So in August, his creatinine is still high 1.7. It was managed with Advograph and leflunomide. In September, he had a jump in creatinine of 2.98 with the fever, with increasing WBC counts. His urine BKV is around 10 to the power of 6 copies, but his transplant Doppler is normal. But urine culture grow Enterococcus fecalis is managed with appropriate antibiotics. So after that also, his follow-up creatinine was still around the range of 2.1 to 2.5. His urine decoy cells were positive. He was given IVIG and he underwent a renal biopsy, which was suggestive of focal tubular epithelial injury with viral inclusions. Again, he was treated with IVIG of He was managed with Advagraph leflunomide. So on further follow-up in November, he still has a creatinine of 2.46. In between, we have done a TTV virus estimation also, which is also more than a 10 to the power of 4 copies. That is around 10 to the power of 9 copies here. So in November, he is managed with IVIG of 30 grams. This is a trend of BKV virus. So currently he is on omnocortic 5 mg OD. CellCept was changed to everolimus 0.25 BD, Pangraph 1 mg BD, leflunomide 20 mg OD, Septron DS 960 half weekly twice, and Silocor. And monthly he is on monthly IVIG at a rate of 0.5 grams per kg.
Maybe I will take, thanks Gokul, like maybe I will take this session from here onwards, like for a good discussion from the audience. Like, no, what is the peculiarities in this case? Like, no, we had seen a very early onset BK viruria in our patient. Yes, we see in some of our patients, like, no, having an early onset BK virus whenever we have a transplant hydronephrosis in the early period. But this is very, very early. In 3 weeks itself, like, no, we had a very significant, more than 10 power 7 of BK virus in the urine was there, which is very like, no, means for the common duration of presentation of BK virus in the literature is from 3 months to 12 months. And many of our colleagues also like, no, usually see the BK virus nephropathy in these periods. Even KDIGO and other guidelines also suggest to monitor BK virus once in a month for the first 9 months and once in 3 months for next 2 years. The usual recommendation given by KDIGO and other BK virus group. But in this patient, like, no, we had a very early onset. So in the and also not only he had a BK viruria, he also had a drain infection. So he had some pelvic abscess also. We had to reduce his immunosuppression, but we reduced immunosuppression like, no, in the very early post-transplant period itself. So we had a very always concern about like getting a rejection, subclinical rejection. So in creatinine is always like, no, in the range of 1.6, 1.7. He has reached an adequate creatinine of 1.1 in the first week. Later, like, no, as always, his creatinine was in the higher side. So as we were giving a reduced immunosuppression, this patient, I think Dr. Subbarao sir also know about this patient. We had a discussion in our department meeting also. So we have reduced immunosuppression, but in my mind, like, no, there is a high concern of subclinical rejection was always going on. So this patient, we added leflunomide. So leflunomide, we know, like, no, in some centers we are using, like we used, means we still use in CMC Vellore, like had a training from Vellore. So we still use leflunomide for all our BK virus nephropathy in those patients. And we have published that in Indian Journal of Nephrology, like, so where we see, like, no, after addition of leflunomide, there was a stable graft function in our case series. So it has both as antiviral and immunomodulatory effect is there, so that we use commonly in Vellore, so that only, like, no, I used in this patient. And even after reduction of immunosuppression with addition of leflunomide, this patient, like, no, his BK viruria was in the higher range only. So in that scenario, started using a monthly IVIG of 0.5 gram per kg every month. Almost like, no, he has received this for more than a year now. So after this only, you can see the curve, like, no, that urine BK virus has started declining. By this time, the urine BK virus started declining, his creatinine was slowly worsening. So in that juncture only, I done a biopsy to look for any rejection that he had, because like we have kept him in a minimal immunosuppression. At the same time, we have done a DSA level and the TTV torqueutinovirus also, but biopsy did not show any rejection, and tenotorquevirus is in, like, no, more than 10 power 10 is in more than 100 crores values were there, and DSA was negative. So
Dr. Saravanan, just
yes,
a small answers because we are leaving time. Shall I start some questions for you?
Yeah, sure. I just finished this one. So, what like no, what we can do means what we should have done like no for the better means for the betterment of this patient. So we have a open discussion like no means we get an opinion from all of you.
Thank you. Thank you for the perseverance management of this patient, and you are coming out well with the patient's good results. And before starting the ball roll, let me ask one thing: is urinary BK virus PCR is a reliable marker to assess the activity? Many times it may be positive even the activity has gone. It will be positive for many months actually. What we have to do is plasma PCR
The
quantity.
plasma is also in the higher side. It is more than 10 power 4 only for this patient.
But in between it become negative, no? It's absent. Only viruria will be, you are monitoring only viruria.
No, viruria, the thing is like, no, if it's should take it significant when it is more than 10 power 7 only. So if it's more than a 1 crore only, you should take as a significant. It was always more than a crore.
Okay. But is it a marker for monitoring actually for BKV?
I think if you have more than a crore count, it's
Okay.
suggestive of a significant,
Active.
it's just very active. It's very
Okay.
very unusual to have the viruses less than a crore and be clinically manifesting.
Okay, sir.
I think let the ball be rolling. See what I would have done in this patient is that when we have this BK virurias we do at the end of the 1 month we do the urinary BK viruses and assess the if it is more than a crore we will cut down the immunosuppression drastically. And then do the virus levels in the urine almost every 2 weeks. Make sure that's falling very significantly and sometimes disappears.
Okay.
Then only increase the immunosuppression. Till that time, withhold the immunosuppression. You have to wholeheartedly treat this BK virus. You just touch and go doesn't help. You have to withdraw the immunosuppression as low as possible and wait for the virus to come down. Once you are safe that it's less than 10,000, less than a lakh, then you start introducing your immunosuppression. Otherwise, this will never leave the kidney.
Definitely, sir. Sure.
It will keep coming up, and you will have
early transplant period, sir, because like no, the rejection is always in our mind, no, sir.
No, that's always there. There's no doubt about it. But here, the problem is unless you get rid of the virus, you won't be able to manage this patient because his graft life as such has come down significantly. The long-term outcomes are not that good. So you have to hit it on the head. Otherwise, it won't go.
Another one point I have noted in the case, like actually when you saw the biopsy, first you biopsy the patient, showed the borderline changes suggestive of acute cellular rejections. And you pulse the patient. No,
I'll also see the histology of BK virus nephropathy mimics acute rejections.
Okay, sir.
Okay, so you have a doubt here. See, whether there is an associated, most likely if there is a significant BK viremia or BK nephropathy, the predominant effect is the virus effect. So you have to handle that. You may see some kind of a little bit of type 1A, 1B acute rejection. I don't think you should give importance to that. You have to concentrate on the virus, make sure the virus levels falls, and then increase the immunosuppression or reintroduce immunosuppression if you had already withdrawn.
No,
in our center,
patient is add only Advagraph 1 mg once.
Yeah, when
Advagraph 1 mg once daily, and
I don't think you should give even that. I think you have to withdraw completely.
Yeah, in our center, we made it mandatory that whenever you find interstitial inflammation suggestive of rejection, we often do SC40.
I think he had definitely BK nephropathy because there are viral inclusions on the biopsy. So he had
the pulse, steroid pulse would have precipitated and would have caused the non-remission of.
Yes. I think that's what I'm saying. That's why what I personally feel is that you have to hit it very hard.
Yeah.
There is no way.
Yeah. Dr. Vasant? His Vasant is there?
Yes, sir, I am here.
Your inputs in this case, please.
It's an interesting case. It's very difficult to manage BK virus nephropathy, that too in very early transplant. And we all tend to reduce the immunosuppression. The one thing that I also used to give leflunomide, and I think Saravanan knows, and both got trained in Vellore, and we used to give leflunomide for all BK virus nephropathy cases. And only thing is like leflunomide is also an immunosuppressive drug. It's used for rheumatoid arthritis, and it has some good immunosuppressive property, some antiviral property also. But I always give leflunomide once I stop MMF completely. Then it's like and I will reduce some amount of tacrolimus, almost 25 to 50%. Tacrolimus also I will reduce, and most of the time I will give leflunomide after completely stopping MMF, not along with not just reducing the dose of MMF alone may not be enough sometime.
Yeah.
And otherwise, it's like only option is IVIG, and high dose IVIG we have to give. And if it's not clearing up and all, then that viral load itself tells it's not easy to clear in this patient. It will take some more time. And first biopsy showed an acute cellular rejection. Whenever you see acute cellular rejection along with a lot of plasma cells in the interstitium, you should think about viral infections, especially BK virus infection. That's another clue. It's like most of the time you won't get SV40 positive in very early stage. You may miss because it may mainly involve the medulla, and most of the time we concentrate on cortex, and this BK virus nephropathy mainly involves the medulla, and you have to give adequate medullary tissue to find out BK virus nephropathy. And the only clue is that a lot of plasma cells around that around the interstitium will tell this some amount of viral infection is there around. So that will give a clue. And
Thank you.
obviously we have to go for plasma BK viremia alone. That's the only I used to check monthly once, and whenever level goes more than 1,000, I start reducing immunosuppression.
Thank you, Dr. Vasant. For the audience, another clue is that patchy inflammations patchy inflammatory infiltrates always should suggest BK virus nephropathy. And the dose of leflunomide usually 100 milligram for 5 days followed by 20 milligrams OD for 3 months, no?
Leflunomide we use indefinitely, actually, sir. We reduce also for some time.
Okay. Initial loading dose should be 100 milligram per
100
day
mg once daily for 3 days. Yeah, that only.
It is, sir. Okay,
It's a
fine.
very long-acting drug. It's like it will take a long time to get into action.
Fine. Another one, what is the protocol for IVIG for refractory? When do you call as a refractory BK virus nephropathy?
There is no such definition in the literature, but
Okay.
this patient looks like a refractory thing only. But there are usage of IVIG in BK virus, like two publication is there, one from US and one from Iran. So what they used like IVIG, like kind of a single dose only, 2 gram per kg per day, not like continuously like every monthly they've used.
Okay.
We don't know, like, no, for this patient, I have just followed this one monthly IVIG.
I think there are two ways. One is you give intermittent doses with the interval of 2 weeks to 4 weeks, or
Okay,
give
sir.
a large dose, single large dose. These two protocols are used.
Okay.
But I think we feel safe with intermittent doses.
Okay. So how many dose? What is the dose? And
There's no limit to the doses. It all depends upon the clinical. If the BK virus.
How much you use per dose? How much you use per dose actually?
I think we used one. I don't remember the dose, but I think about
2 gram per kg is a recommended dose, sir.
Yeah.
For a treatment purpose.
Yeah.
So intermittently we are using just 0.5 gram.
I think that's been accepted by the many people.
Okay.
Use that.
Okay, fine.
Because this is used only when you have a suspicion of underlying, acute rejection. So you have to cover that because you have withdrawn or reduced the immunosuppression so much. To cover that, you give IVIG. It also has some antifungal, but the antivirus, but predominantly it is to cover the low immunosuppression.
Panelists, any experience of you combining tacrolimus with mTOR inhibitors sparing MMF for these kind of patients?
Me?
mTOR inhibitors plus CNI taking out MMF.
Yeah, we have for 10-15 patients on combination of both mTOR inhibitors and the tacrolimus. But the problem is one accelerates the risk of the other medicines. So increases the toxicity. The mTOR inhibitor increases the TAC toxicity, and TAC toxicity increases the mTOR toxicity. So you have to be very careful with your dosing. Have to be careful with the levels, and keep monitoring the counts. That's also very important.
Thank you. Any experience of ciprofloxacin in refractory BK virus nephropathy?
No.
Okay. Dr. Vasant, your experience? Any experience of
No, sir, I have not used levofloxacin.
even
or
CMC,
ciprofloxacin.
Vellore?
No, in CMC they use only leflunomide, I think, and I don't think they have used levofloxacin or ciprofloxacin for that indication.
Levofloxacin was used before when Dr. G.T. John was there, but they find a lot of interstitial nephritis. They had a confusion whether it is because of it could be because of BK or because of
Drug
quinolones.
induced.
It was used before when George T. John was there, and they have switched to this protocol. Even they have tried a pseudophobia for some few patients in those initial maybe in 1990s, 2000, those period.
Okay. Virus-specific T cell therapy, do you have any idea about that actually?
Yes, sir. The newer molecule has come actually. Maybe the Gokul, then a subsequent slide, maybe it's out of time. There's a newer molecule has come. His name is some PC. What is that? Gokul? What is the name of that thing? Some viral specific T cell therapy is approved in US now actually.
Yeah.
It's for BKV, CMV, EBV, and all post transplant.
It is showing a very promising effect of 40 to 50%.
Posoleucel. That is someone is Posoleucel.
Posoleucel. Dr. Kamini, she has posted. Do you have any experience of that?
It's just approved in US only, sir. No test to come.
It's in a phase 2 trial, sir.
It's a phase 2 trial.
Phase 2 trial, right? Okay.
We have also have neutralizing antibody targeting BK virus, sir. MAU 868.
Okay.
It is also in a phase 2 trial, sir.
Fine.
There's some monoclonal antibodies also.
We have some very promising antivirals on pipeline. I think it's going to won't be that difficulty in the future to manage these patients.
Thank you. Had a very good discussion on this BK virus nephropathy, and we have let some questions in the first presentations actually because of short of time we skipped, and we can have some 1 or 2 questions for Dr. Vel Aravind Subramaniam, sir. Dr. Velar, sir, regarding the iliac vessels, last case, they have, for iliac vessel blowout, they have excised and tied iliac artery. What is the way to prevent the lower limb ischemia? Is there any other interposition grafts? Is there any way to prevent that? Is lower limb ischemia, when you handle iliac vein thrombosis, when you have to ligate the iliac vessel, external iliac? I think it's not there. In your case, what you have done, Dr. Ajay?
Sir, we have just tied it up, sir, and
just ligated.
We've just ligated it. And during when we removed the complete external iliac artery, there was a discussion about bypass, but we were just more worried about spreading the disease to the next limb also. So we didn't go for the bypass. Sir.
Okay. Any interposition graft can be used to prevent limb ischemia? Is there anything you have?
No, sir. Last time, the only thing the vascular surgeon was telling us was bypass.
I don't know. They had a time. It was a very emergency surgery.
Yeah.
The blowout. I think they're just gone in there to save the life.
Yes. We were about to take the limb also, sir. We were ready.
Yeah. That's what I'm saying. I don't think there was any planning. There was any planning to do anything there. Yeah.
It's a very interesting. The clue for vaso-invasive infection is that is acute patchy necrotic necrosis along with the bleeding, retroperitoneal, that psoas bleeding.
Psoas bleeding, sir.
Yeah, that is it. I had one patient.
With this mucar, what does it do is it thrombosis at the same time ruptures the vessel.
Yeah.
That's the problem. The thrombosis will produce the cortical necrosis, and this rupture will produce the bleeding. So it is a double whammy.
Yes. Yeah, thank you very much. And we have said many questions, and no further questions and all. We can wind up the session. And very thankful for the speakers who had presented nicely and managed the case beautifully. So that gives a lot of insight to us to manage such kind of cases when we come across. And the panelists, they have spent a time and their discussion was awesome. And we have learned a lot about this infections. And thank you, Subbarao sir. Thank you, Dr. Vasant. And thank you, Dr. Subramaniam, for being as a panelist. And thank you, Dr. Ajay and Dr. Saravanan and Dr. Gokul. And you have taken the time to prepare your slides and you have presented it nicely. And I must thank the delegates who have attended this meet, and you have been the pillar of support for the continuous meeting. And we welcome the centers to present such kind of cases every month so that we can learn from each other. And every month, Saturday, first Saturday, we'll have this meet, and we will see in the next meeting in January. And I must thank the MQ team for providing the technical support. And thank you one and all for joining us for this 51st Peculiar Series meeting. Thank you, sir. Thank you all for your
Thank you.
time.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank you. Ajay has managed this case very well, but